Hello and welcome to the UT Health East Texas Virtual Education Series. Today's presentation topic is Menopause, a time of transition, featuring Dr. Ann Abrameit, board-certified obstetrician and gynecologist at UT Health East Texas Physicians Clinic in Lindale.
Today our topic is going to be menopause, a time of transition. So with the baby boomers aging, approximately 90 million women will enter menopause by 2060. And as I hear from many of my patients, we're not ready to stop. Because women are living longer, they will live an average of 30 to 40% of their lives post-menopause. And menopause can come at a time when a lot of other life stressors are happening, and this kind of goes and creates a perfect storm of chaos for the midlife woman. Other things that are happening at this time, many women are caring for elderly parents, kiddos are leaving the nest, so they're facing the empty nest. Perhaps a husband is retiring or the woman is retiring, and then you add in all the hormonal changes of menopause, and you've got a perfect storm of chaos. But the good news is there is life on the other side of menopause, and there are treatments for some of the most bothersome symptoms. So how do we define menopause as a physician? Menopause is technically when you've gone 12 months without having any bleeding. And if you have any bleeding after that 12 months, that's called postmenopausal bleeding, and that's something your doctor should evaluate. But what a lot of ladies don't realize is actually once we get through menopause, life can look pretty good. But menopause has this really mean younger sister called perimenopause, and she can last for 5 to 7 years before we, or even longer, before we actually get to stopping having periods and through that transition. And that's when I see many patients come in to see me with symptoms. So common complaints during this perimenopausal or menopausal time period, well, one is hot flashes. Now you might be surprised to know not everybody has hot flashes, and there are certain demographics where hot flashes are worse than others. But about 60 to 80% of women will have hot flashes, and these can last much longer than is typically thought. In fact, I have some ladies in their 70s that are still having occasional hot flashes. Things that worsen hot flashes include smoking. Smokers are going to typically go through menopause earlier, and they're going to have more and severe hot flashes. Obesity, if you're Black or Latina, you tend to have worsening hot flashes. And then white ladies and Asian ladies have decreasing amounts of hot flashes. Hot flashes on their own are an increased risk for cardiovascular disease and for low bone density. So there are reasons we would want to augment ladies if their hot flashes are severe with perhaps a hormone, because we know that we can potentially be affecting their heart and their bones in a good way. Also complaints of vaginal dryness, pain with intercourse, poor sleep. I see that a lot in perimenopausal ladies. That can be related to hot flashes, but again, those life stressors that we talked about play a role in that as well. Low or no sex drive, a common complaint. You know, ovaries make a small amount of testosterone. So when those ovaries quit producing estrogen and stop making any testosterone, common complaints are a low sex drive. Mood swings, I feel like a crazy person, and I kind of remind my perimenopausal ladies, remember how it felt when you were going through puberty and having all those hormonal changes? Well, here, welcome to puberty part 2.0. So we're back to having those hormonal mood swings. Depression, menopause is what we call a window of opportunity for depression to develop. In fact, even some ladies that didn't have depression prior to going through the menopause will experience depression in menopause. I also see a worsening of anxiety during this time period, especially with COVID. We've seen anxiety levels rise across the board, so depression and anxiety can start or worsen during menopause. Urinary symptoms, including getting up at night a lot to go to the bathroom. So not only may they have more urinary tract infections, and we're going to talk a little bit about genitourinary syndrome of menopause, but these are the ladies that say, you know, I used to have to get up once a night to go to the bathroom, now I'm having to get up 4 times a night to go to the bathroom. So that's also disrupting sleep, along with the hot flashes. So in 2014, a new term was coined that replaces what we used to call vaginal atrophy or dryness, And the new term is genitourinary syndrome of menopause. And this can cause irritated or painful sex. It can cause some of the urinary tract symptoms that I described because the bladder is very dependent on estrogen, just as the vagina is to remain healthy. So how can we treat some of these symptoms for menopause? Well, it differs for every woman, and that's why I think it's great for you to have a conversation with your doctor, because some women are going to sail through menopause with very few symptoms and not have an issue at all, or be able to manage their symptoms without using hormones. But other women are going to have severe symptoms that are going to bring them in to talk to their doctor. Treatment differs for ladies that have a uterus or do not have a uterus. If you are taking an estrogen preparation and you have a uterus, you also have to take a progestin. If you don't have a uterus, so you've had a hysterectomy at some point, you don't have to take that progestin. So treatment needs to be catered to those women. A lot of ladies come in and say, do I need to have my hormone levels checked? And that's a really controversial question. Some people are doing saliva testing. The position of the North American Menopause Society is that saliva testing is not reliable and is not the way to go. I think most practitioners, including myself, base things off of symptoms. If we have a lady that is on hormones and we feel like we need to adjust the hormones, that might be a reason to check. But to just do a blanket check of your hormones when you're a 42-year-old lady having the occasional hot flash and irregular bleeding is probably not going to benefit you, because hormone levels vary from day to day in that age group. Sleep issues. Super common in this time period, as I mentioned, due to stress. Sleep apnea worsens, insomnia worsens. We see restless leg syndrome pop up and joint pain. Again, all welcome to middle-age issues. And then exacerbation, as I mentioned, of depression, anxiety. And cognitive behavioral therapy can be helpful for that, as well as antidepressants. And there is an antidepressant that is also FDA approved for hot flashes, so we have that option when we're treating ladies. What are some of the non-hormonal treatments that you can try to control hot flashes? These are some obvious things, but sometimes when I mention these to ladies, they're like, oh, well, those are 2 or 3 things I can easily do at home that I don't have to take a pill for. Turn down the thermostat, avoid comforters, use a lightweight sheet that you can pull on and off of you. Wash your hands in cold water, put a small fan by your bedside and some cool water to sip in at night. They do make a cooling pad that you can hook up. It has a small motor. It's very expensive, but many ladies have said that a good night's sleep with that cooling pad was worth every penny they paid for that. Stop smoking, lose a little bit of weight. We know that if you lose 5 to 10% of your body weight, you can significantly reduce your symptoms of hot flashes. And lower stress. Now, of course, as I mentioned, that's a very difficult thing to do, especially in this time period, but there are things that you can do, such as relaxation techniques, yoga, commiserating with a friend, start a menopause support group once a month. Those kind of things all help. I mentioned antidepressants, and those can also be used for premenstrual syndrome, PMS. Gabapentin is a non-hormone drug that's sometimes used for pain relief that also helps with hot flashes. I mentioned relaxation and yoga. And then if you're having significant vaginal dryness, which that's something we typically see after you've been in menopause for a year or longer, there are many lubricants and moisturizers out on the market that are helpful for this. So a lubricant is different than a moisturizer. A lubricant is something you use when you're having intercourse with your partner, and a moisturizer is something that you would use every other day or every third day that actually helps draw moisture into the vagina. So that's 2 different types of over-the-counter things you can try. There's been a lot of talk and some pretty good small studies showing success of using the vaginal laser to kind of rejuvenate the vaginal tissue, and that's particularly helpful for ladies that have a history of breast cancer and cannot be on hormonal therapy. So what are the types of hormones that we can use in menopause that can be helpful to women? The first one is, of course, estrogen. So menopause happens because our ovaries stop making estrogen. So we need to supplement that in ladies that, again, are having significant symptoms. And there are so many ways you can take estrogen. So I like to tell women that menopause treatment is an art. It's not a science. You can use a pill, a patch, a cream, a vaginal ring. There's many ways that you can get this into your body, and some work better for others, and some have lower risks for ladies like, let's say, that have had a prior heart attack or stroke than others. So that's always a good conversation to have with your doctor. As I mentioned, if you do have a uterus, you've not had a hysterectomy, you do need to take progesterone as well, because that prevents you from getting uterine cancer in the future. And then the role of testosterone. So testosterone has been very controversial, but I have seen great success with women who are menopausal. I don't use it in premenopausal ladies. They do have a couple FDA-approved drugs for low libido or low sexual desire in premenopausal women. But in menopausal women, testosterone can be an effective adjuvant to help bring up your sex drive. And even if you're having difficulty achieving orgasm or loss of sensation with intercourse, testosterone can be very helpful. In all of the studies, they have shown that estrogen is the most effective therapy for moderate to severe hot flashes. But again, we want to effectively counsel women and use it with caution if the woman has a history of breast cancer or any other female cancer that could be hormone mediated, or if she's had a heart attack or stroke. There is a FDA-approved medication called vaginal DHA, prasterone, and that can be used for vaginal dryness as well, and is probably safe in breast cancer survivors. And then ospemifene as well for vaginal dryness. That is okay for people that have already had breast cancer. So I just want to encourage women that there are treatment modalities out there. You don't need to suffer in silence if you are having menopausal or even perimenopausal symptoms that are affecting your daily life or affecting your marriage or your sexual relationship. You need to come in and speak to a provider because there are things we can do to help. So here are a few questions that we've received. Number one, boy, this hits home. How do you control weight gain during menopause? Weight gain, a little bit of weight gain during menopause is a fact of life. They joke about the meno belly. It's a true thing. But as we become more sedentary, as these life stressors increase, it actually increases the hormone that is responsible for making us hungry. It's a hormone produced in the stomach called ghrelin. I like to think of it as ghrelin, because it makes your stomach growl, it makes you hungry. And the other thing that increases ghrelin, so actually makes you hungry, is lack of sleep. Studies have shown that if you get 5 hours or 6 hours of sleep or not a night versus what we recommend 7 to 8 hours of sleep a night, your ghrelin levels are significantly higher. So there are multiple things that combine in menopause, again, to cause weight gain. Exercise is important. We know it's very important for cardiovascular health. It's important for maintaining bone loss, but it actually isn't that important for weight loss. Dietary changes account for about 90% of weight loss, and exercise we know is important for maintaining weight loss once you've lost the weight you want to lose, but isn't going to be nearly as effective as healthy eating to control weight. And when I say healthy eating, the studies have shown that particularly for women, a higher protein diet. I'm not talking something extreme where you never eat a piece of wheat bread, but something that is higher in protein and a little lower in, for sure, processed sugars seems to help midlife women better than other typical diets. Will menopause affect my sex drive? We've covered that a little bit. I would say absolutely. Menopause and perimenopause both affect sex drive, along with relationship issues and all the other stressors that I talked about. You know, the biggest sex organ that we have is our brain. So we can treat the vaginal dryness, we can treat the pain with sex, we may even be able to increase libido a little bit, but really it's our brain that is the biggest sex organ that we have. So we've got to address all of the issues, whether it be relationship issues and stresses that come along with midlife, to really improve someone's sex life. The last question, do I still need a Pap test and a mammogram after menopause? Again, that's pretty dependent on each woman. If you've had a history of abnormal Pap smears or had to have Pap smears on a yearly basis versus every 3 years, then we're going to probably recommend you still get an occasional pap smear after 60. Although most of the recommendations are that you stop at 65. If you've had no history of abnormal pap smears, we can stop doing those at 65. Mammograms are kind of the same thing. If you had a mom that had breast cancer or a sister with breast cancer, we're going to watch you a little closer than we are the person that has no breast cancer history, and we might space those mammograms out. And again, typically at 75, we might stop mammograms in a low-risk person.
We hope you enjoyed the presentation today. For more information about scheduling an appointment with Dr. Abrameit, call 903-881-5799 or visit us at uthealthiestexasdoctors.com. Our next virtual seminar will be announced soon. Follow us on Facebook to stay up to date on upcoming events and seminars. Thank you for joining.